Welcome back, folks. If you were here before when I suddenly cut out, my access to live was suspended. TikTok said that I was engaging in bullying and harassment. And so I sent an appeal and my access was restored within like 5 minutes. So man, that was wild. I was trying to figure out what I could have said, but there's just no way. I'm just not a harasser or a bullier, so I have no idea what that was about. That was the first time that has ever happened. That was so crazy. I was just talking to you guys, and man, it was such a good live. I had like 70 people watching, and the questions were piling up. I love when the lives are like that, when there's just so much engagement and things are just flowing, and then the screen just goes white, and it was like, you have been suspended until January 26th. And it said it would take them 24 hours to process the appeal, but I got the notification almost immediately, so I don't know how that works. I have seen other EMS lives drop due to trolls. Yeah, Greg over at Shade Tree Cardiology had the same thing happen to him during a live. And I think his was restored pretty quickly as well. And Jenna Roxbury, I don't think she didn't have a live suspended, but she got a mark. In fact, I think she's had a couple of marks on her account now. But that was crazy. That was crazy. But thanks for everyone who's come back. Appreciate it. I was trying to, I really need, what I really need to do is make sure that people are following my YouTube channel as well. I take my lives and I repost them there for anyone who wants to watch them. But at the very least, if people are subscribed to that YouTube channel, I can go live from there as well. And I guess I could do it from Instagram as well. I sometimes cross-post to Instagram. Some people just have sad little lives and need to cause others trouble. Yeah, it does happen. Do you have a link to your YouTube? It's EMS Avenger on YouTube. Just got a call about to head out. Please be safe. You love the YouTube channel, really? Are you just like watching the lives on there? Thoughts on pre-hospital administration of antibiotics, primarily Rocephin for sepsis and SIRS. The only antibiotics you're going to see administered in the field in the U.S. is something broad spectrum. Overseas, they do actually, do Vanc and stuff like that, or something that requires specific types of dosing. In the U.S., what we found is that pre-hospital ABX is not really affecting mortality or morbidity when it comes to sepsis. Maybe there's a slight benefit in services that have really long transport times, but we haven't seen the evidence of it yet. Now, that doesn't necessarily mean that they shouldn't administer them. Sometimes we just do it because we're the first line healthcare contact and we have that capability, and so why not start it? I think that the services that should carry antibiotics are very progressive services where you can be very, very confident in the field differential of those medics. How about ANSEF for trauma? I'm not sure if sure, why not? They're going to get it, so why not? At the same time, why? I don't think that time to ANSEF is really making a huge difference when it comes to trauma. I'm back in the station recovering from moving a 600-pound patient. Not fun. Yeah, that doesn't sound fun. How about sepsis for traumas? What do you mean? Or did you mean to say ANSEF for trauma and you corrected yourself? So speaking on IV as a basic, Minnesota EMTs can be variants for it. Different states can make those variances. I think South Carolina had some sort of variance for basics to intubate at one point. Yes, I listened to YouTube while cleaning the station. I posted a few comments to them. Oh, have you really? I'm sorry that I missed them. I haven't gotten any sort of, maybe I have notifications turned off. But thanks for listening. I appreciate that. I had one today that I need to post up there. I am back. For those that were here before, I received a notification that I was suspended for bullying and harassment. I immediately appealed it, and my access was immediately restored. The quicker we get the ANSEF, the quicker to OR. Yeah, I mean, that's fair. I mean, like I said, I don't see any reason not to give ANSEF in trauma. Effect of citrate on 2,3-DPG in packed red blood cells. That's a good question. For those of you that don't know what 2,3-DPG is, 2,3-DPG is a chemical that essentially pries oxygen off of hemoglobin, and it can be subject to very wide variances in how quickly or slowly that it does that, depending on where you are on the oxyhemoglobin dissociation curve. So there are some conditions that will cause 2,3-DPG to release oxygen much quicker. That is when you're in right shift. And it will, when you're in left shift, it will cause 2,3-DPG to hold onto it. And the benefit of, sometimes it's beneficial for that 2,3-DPG to release it earlier, just making sure it's getting that oxygen out. But sometimes that isn't so good because it releases it much faster than it should. So instead of releasing it peripherally, it releases it almost immediately, and so you have not so much available O2 by the time it gets to the peripheral areas. As far as the effect of citrate on that, that's a good question, and I'm going to have to read up on that. Here's my unicorn Army General. We just obtained ANSEF for open fractures, but it's a small priority in our treatment. Can you do a video explaining aberrancy and aberrant rhythms? I am going to be doing more EKG stuff, so I'll probably get to that, yeah. Thoughts on TXA, or Tranexamic Acid? I think that, you know, if you are not an organization that can carry whole blood, you should be carrying TXA, for sure. I'm in Wisconsin medic school, but work in Minnesota. My scope is more broad than Wisconsin. ANSEF is used fairly common for long bone open fractures in pre-hospital setting. Any experience with duonebs or new protocols? Just added them. You just added them? I mean, like, duoneb is like the standard of care for respiratory calls. How are you just getting, I'm assuming you're just getting Atrovent, so you're creating duonebs. It's a two-pronged approach. You have the beta stimulation with the albuterol, and you have the smooth muscle relaxation with the Atrovent. And it also has some anticholinergic effects as well, so it can dry up some secretions. You should be using that liberally in respiratory calls. They're not so beneficial in pneumonia, but for COPD and asthma calls, absolutely. How is the 8 versus the 16? Oh, you're talking about the Scotch? Well, the 8 versus the 16 is noticeably better. 8 versus, don't they have a 10-year? I think they have a 10-year, don't they? 8 versus 10-year, there's not that much of a difference. But 8-year is still fantastic Scotch. Do you think that EMS is moving towards carrying blood products on the ambulance, and do you support it? Well, they are. It's not what I think. They absolutely are. There is definitely progress being made there. I don't want to say a lot, but it is happening now where many ambulance services are starting to carry whole blood and using it to good effect. And we definitely have data showing that outcomes are better when we administer whole blood. Bleeders get blood, right? And when you give a isotonic crystalloid instead of blood, you worsen the lethal trauma diamond. And so we absolutely need to be heading towards carrying whole blood. It needs to be the I hope that within 10 years it's the industry standard. I realize it's not logistically feasible for everyone, but we should definitely be moving a lot more towards that. Where did you get that shirt? Everyone loves this shirt, man. I got it from Figure One. They are like a social network for healthcare providers and any sort of pathophysiology that you're interested in. They have, I guess the equivalent would be a subreddit for it within there. And I was, for a time, very active within Figure One. And I got on the radar of some of the administrators, and they asked me to do a promotional video, which I did. And so they sent me some swag, including this t-shirt. I don't know if it's available as merch. You can try. I do also love this shirt. It's a great shirt. TXA versus calcium or both. I don't think that they're mutually exclusive, but you're going to get more benefit out of calcium. I would definitely administer calcium with blood, though. Got someone here that loves duonebs. Yeah. I haven't seen Minnesota Scope outside of Mayo. Looks like AEMT. Anyone else love learning from Ninja Nerd? His cardiology lectures are fantastic. Is he on? I don't know if I follow him. Is he on TikTok? What do you think the most underutilized medication or piece of equipment is? Your end tidal. Your end tidal is your most underused piece of equipment. It's not just for confirming tube placement. You know, it lets you know immediately how that person is doing, whether they're heading towards respiratory arrest, you know, where they are kind of as far as respiratory acidosis. You know, people who are experiencing sepsis and that sort of thing can also kind of let you know where they are. End tidal is definitely one of the most underutilized pieces of equipment on your truck. As far as the most underutilized medication, that's a good question. Oh, your pain medication for sure is the most underutilized medication on your truck, your narcotics. People conduct themselves like gatekeepers in EMS instead of providers. And they act like that the narcs are something that they're preventing people from getting, instead of understanding that it has been given to you to help patients who are in pain, and that they don't have to be in absolute agony to deserve to get it. Our agency had TXA, but with our protocol, our patients had to be decompensating badly before we could use it. Oh my God. Okay. I don't have any words for that. Also, Solumedrol with the duoneb. I mean, yeah, if your patient's in respiratory distress, you know, and is not getting better with some immediate interventions, then you definitely want to get a corticosteroid on board. I'm sure there's going to be a lot of people that just say, if your patient's in respiratory distress, just go ahead and give them the steroids. They don't all need that. They don't all need that. Some of them just need bronchodilation. And I've had plenty of patients, asthmatics or COPD patients that, you know, they just ran out of their duonebs, you know, or ran out of their albuterol, or their oxygen ran out, or what have you, or they had some sort of trigger, and all they needed was bronchodilation. And they were fine after that. Because the problem is that when you give them that steroid, now they have to be put on a course of steroids that they have to wean off of over the next week to 10 days. And that sucks. Those things are horrible. And I mean, when I have to do that, I had to do that a year ago. I had injections of steroids into my ears because I had tinnitus. And I got put on a steroid regimen after that because obviously I had to wean down. And I had insomnia for 10 days. And I was going insane. So, you know, make sure that the patient actually needs the corticosteroid. Our protocol is actually you administer corticosteroid only if they're not improving with your other treatments. Listening to you and the sleepy paramedic definitely inspires me to go for my paramedic. Oh man, I really appreciate that. I hope you do. I hope you do go for your paramedic. Can you do a video on cardiac asthma? I mean, are you talking about like when somebody is in pulmonary edema and they end up wheezing? I just don't like looking at that as a pathophysiology. Generally speaking, your pathologies are going to look like this. You can start here. Do you have a flow to problem or a flow through problem? A flow to problem is when you have narrowed and inflamed airways from some sort of process. And a flow-through problem is when you're that flow to the air can't get down to where it needs to go because of those narrowed airways. With the flow-through problem, you have a gas exchange issue. And the gas exchange issue is where like CHF and pulmonary edema comes in, because you have all that fluid coming in and washing out the surfactant and collapsing your alveoli. That's the flow-through problem. The flow-to problem is when you have bronchoconstriction from a process like COPD or asthma or pneumonia. And if it's a flow-to problem, you want to administer something to help open up those airways. If you have a flow-through problem, you want to do something that's going to create positive pressure in the distal part of the airways so you can have that exchange again. Every once in a while, someone that has that pulmonary edema can also have a reactive airway where there's this bronchoconstriction. If there's bronchoconstriction, you are now also experiencing a flow-to problem, so it's appropriate to give a bronchodilator. But if you don't have a flow-to problem, just focus on the flow-through problem. Tell me if that helps or not. I don't know if it's been asked or not, but where did you get that t-shirt? I got the t-shirt from Figure One. You can look for them in your app store. It's like a social media for medical providers. I believe only our critical care ambulance carries blood. Yeah, I mean, it's often carried just on critical care ambulances, but a lot of services now carry them on 911 units. Had first mega code test today and nailed it. Awesome. Awesome, awesome, awesome. Good for you. Ninja Nerd. Oh, yeah, I do know Ninja Nerd. Yes, I've seen his videos on YouTube. Have you seen or heard of a paramedic who does not give any meds? Yes, especially pain meds. Like I said, there's a lot of people in this field that feel like they need to be gatekeepers rather than providers. And they will gatekeep narcotics, but then they also aren't very confident when you really, really expose that inner paramedic, and so they don't want to give medications because they're afraid of getting it wrong. And so they'll come up with some weird reason why they didn't get it. I heard a call-in where somebody was transporting someone in anaphylaxis, and they said that they didn't give epinephrine because they wanted to get the patient into a more stable environment. Like, what? Why are you even a paramedic at that point? Can you talk about treating hypertension and head bleeds? Both services I work for say do not treat. No, of course you don't treat. That hypertension is attempting to compensate for something. Now, there's a certain point, where, well, no, let me back up from that. No, you don't treat hypertension and head bleeds. I don't have a way to organize my thoughts very quickly on that, but I would not be treating hypertension and a head bleed, no. That hypertension is compensating and helping them maintain a certain cerebral perfusion. I trust N-Tidal more than SpO2. There's this weird dichotomy that needs to stop where people are creating a false equivalency between N-Tidal and SpO2. They both provide you needed information, and one is not necessarily more important than the other. They are both very important on a respiratory call. And SpO2 has more value than just giving you their oxygen saturation. That pleth wave, also can tell you a lot of things right off the bat. It can tell you that their pulses match, that the actual perfusion matches the heart rate, that the pulses match the heart rate, because you can get someone, who has a fast heart rate or an irregular heart rate, and you feel that pulse, and you're like, oh, this doesn't match up at all. And that pleth wave is going to give you that information. If you're watching your pleth wave when you're doing a cardiac arrest, it may be the first thing you see that keys you into the restored pulses. I always have the pleth wave up during a cardiac arrest. If you pause compressions and your pleth wave is still going, you should be able to confirm a pulse somewhere. MAG is very underutilized, it seems. The pendulum has kind of swung both ways with MAG. I don't think that there's not really a body of evidence for its use outside of anything other than asthma. But some people just like to throw it at patients, but it's not without risks. And tidal monitoring also counts respirations for you, absolutely. Wait, how are you live? I need to delete that video. I had posted a video saying what had happened. They restricted my live access because they said I was bullying and harassing. I appealed it immediately, and they restored my access immediately. I would go delete it right now, but I think I would have to end my live to do that. I feel Toradol is underutilized. Some go directly to narcs when Toradol I feel will be better. Absolutely. There's been studies that show that anti-inflammatories are much better at controlling pain than narcotics. And I wish that I had Toradol because I would use that, especially with things like kidney stones, because Toradol is a ureter dilator, and that would be very beneficial there. Most unused equipment, the most unused equipment, the KED, sure. But are we talking unused or underused? Unused means you're just not using it. Underused means you should be using it. And you should not be using the KED for an extrication tool. Demonstrations have shown that there is more cervical movement with the placement and use of a KED than there is with just assisting a patient in getting up and placing themselves on the stretcher. But it's a great pelvic binder. You can't create or stop addiction in the back of the truck. Damn. I don't know if I can like comments, but I wish I could like that one. Yeah. Keep in mind that the people who are drug seeking, who are addicts, if they could have just stopped being an addict under their own power, they would have already done that. And, creating this mobile judgment center where we become a barrier to someone, and someone that's patient harm almost. If they are used to the presence of narcotics in their system, and we say, well, you can't have a narcotic because you are used to the presence of a narcotic in your system. How does that even work out logically? How does that even track? They need that narcotic, and it's someone else's job to help them through getting over that addiction. We're in the middle of that, and so we don't play politics with addiction. Slipping on some 18-year Glenfiddich. Good for you, my man. Or my woman. You would die if you read my old agency's protocols. They claim to be progressive. I thought about paramedic school, not for me. Well, it's not for everyone. So with the cardiac asthma, started with a duoneb, and he frothed on me, and I had to tube him. Well, why did you think that they needed a duoneb? That's someone that had some pretty significant pulmonary edema then, and what they really needed was positive pressure and nitroglycerin. I'm only in medic school. Halfway done. Sounds like CHF. It definitely sounds like, pulmonary edema at the very least, yes. FiO2 versus O-through problem explanation. Thank you so much if you can. You're going to need to clarify that for me. FiO2 basically is the amount of inspired oxygen that you're getting. So, like if I have someone who's on a ventilator and I set the FiO2 to 80, that means 80% of the gas that they're taking from the ventilator is oxygen and 20% is atmospheric. Just got home from ENT class. I love learning from your page. Thank you very much. I appreciate that. Good to see Georgia finally jumping on board with pre-hospital blood administration. Well, we're not carrying blood. I don't know if anyone in Georgia is carrying blood. Maybe, I really don't. Seriously, BLS is epi for anaphylaxis. I'm going to try to catch up a little bit on comments here. Let's see. Pleth is great data. Tell him, Jimmy. Oh, hey, Charlie. How you doing, man? PEA versus perfusing rhythm pleth wave. Right. Yeah, SpO2 in full arrest. Put that pleth wave on. Go to that monitor and select what you can look at and select paddles, pleth wave, and your end tidal. As an AEMT, I've caught patients with PSVT numerous times with SpO2 pleth waves. Yeah, there you go. Well, you can catch that with a pulse too, though, right? If you caught that with a pleth wave first, then something's backwards. Everyone, and I'm not dumping on you. That's great that you caught that with the pleth wave. But as soon as you make patient contact, you should be getting right up to that radial pulse and checking that radial pulse. Hey, my name's Jimmy. I'm a paramedic. What's going on today? 4 milligrams mag for eclampsia. Yeah. You know what they do in a lot of emergency rooms for pregnant women that are seizing? Versed. Most of the time they just go right to Versed. I love Toradol. My floor is also vascular and it's great for ischemia pain. Yeah. Effect of CO2 poisoning on end tidal CO2 reading. Wow. That's a good question. CO has a higher affinity for hemoglobin than oxygen, but does it have a higher affinity than... Well, it's gonna screw it up because oxygen has a higher affinity for hemoglobin than CO2. And actually, the more oxygen that you give, the less likely CO2 is going to bind properly to your hemoglobin. That's the Haldane effect. And so carbon monoxide is for sure going to have a higher affinity than end tidal. Toradol is a ureter dilator. Yes, that's why it's so good in kidney stones. I got you, not Tornado. Did you see the new video from Limmer talking about the new NREMT paramedic test? Any thoughts? Yeah, I actually did a video last month, giving people a heads up on what that test is going to look like. It's supposed to be, the way it's structured is supposed to line up much better with the way you process a call. Multiple choice questions are not intuitive to a lot of people. They don't, it's hard for them to just suddenly be where the question wants you to be when you didn't get on a scene and perform assessment, engage your critical thinking skills that way. So the new test structure is supposed to be better for that. And I've heard from a couple people now saying they liked that a lot better. Yo, my friend, legitimate question. Is there a course you recommend for healthcare staff? What is a M/SRN? What exactly do you want to learn? That's a little bit broad. What advice would you give us for responding to emergencies outside of a hospital? Or is that the same person? Well, that's a weird question. Are you a nurse that's going to be staffing an ambulance? Is that what's happening? Tornadoes are probably ureter dilators too. Very true, very true. It happens in the hospital too. Nurses, docs gatekeep pain medications all the time. Yes. There's a particular doctor in one of the hospitals that I transport to who is just not going to give you permission because we have to call for some stuff, who's not going to give you permission for pain meds and some and some stuff. And they'll say in abdominal pain that it obscures the diagnosis, and we all know that is horseshit. Cardiac asthma is just pulmonary edema, but also with wheezes. Toradol takes time to kick in. If that's me with a kidney stone, fentanyl to hold me over till then. Oh, absolutely. I'm going to give you something right then and there. It's not either or in some situations. With something like a broken bone or anything where there's an inflammatory process kicking in, and you're in 10 out of 10, there's no reason why you can't have both of them. Although there are some reasons why you can't have Toradol, because it increases the bleeding risk. So if whatever I think you're suffering from may have you in an OR relatively soon, Toradol is actually a bad option. Flow through versus flow through, or flow to versus flow through. I've never heard those terms, but I'm a med-surg RN. That's something that I like to use to teach people who are having a little bit of problems developing their strategy for treating respiratory distress. You know, there's some people that will dogmatically want to give albuterol for people in CHF. And albuterol is for something that's a flow to problem, something where you have constricted airways. That's what albuterol fixes. And in most cases of pulmonary edema, they're not suffering from bronchoconstriction. They're suffering from don't you love it when you just lose a word? What's the chemical? What's the chemical that's in your alveoli? Surfactant. They're suffering from surfactant washout from that fluid that's coming across from the capillaries. And so that's a flow through problem. Your gas exchange is limited. A flow to problem is gas doesn't get down. Flow through is that the gas doesn't actually exchange. And so CHF related problems in pulmonary edema are generally a flow through problem, and you should focus on strategies that help the flow through problem. And every once in a while, there's a little bit of mix. You can get some people with pulmonary edema that do have some bronchoconstriction, and it's appropriate to give a bronchodilator at that point. And in CHF, it's great to put people on positive pressure because they do have some problems that need to be overcome through Henry's law, which is when you increase the pressure of the gas over a liquid to allow that gas to get into that liquid. But you're more likely to use both of those strategies in COPD than you are with CHF. Do you have a go-to whiskey? Yes. If I am just going to just buy whiskey, just for sipping, nothing special, then Bullet Rye. Either Bullet Rye or Knob Creek. There's three of them. Bullet Rye, Knob Creek Rye, or Jack Daniel's Single Barrel Select Rye. That's for my ryes. For a Scotch, it's going to be Lagavulin. For a bourbon, it's going to be either Eagle Rare or Buffalo Trace. Also, there's a Scotch called Monkey Shoulder, which is kind of, it's like the best affordable Scotch that you can get on the market. Region 2 finished the blood trial and the state is working on the protocol. Excellent. Our medical director has us do 4 milligrams of MAG for prego seizure, not Versed. I mean, most EMS services, their protocols are to give MAG, but there's just this disparity. When you get to the ER and, someone who's pregnant is having a seizure, they don't often give MAG. Well, I mean, I guess it depends on where you are, but quite frequently they don't give MAG. They just give Versed. Because, the evidence that we have about benzos in pregnancy is just that, if you give it before delivery, it makes the babies a little floppy, but that's about it. It's not toxic to the fetus. There's just some sedation involved. That's all. Had a provider do a precordial thump on a VFib arrest today. Are those even recommended anymore? I mean, they're not really in any protocols, and it's more of like a paramedic flex to do a precordial thump than anything else. This thing really seems to have fallen down a little bit. Let's fix that. I've done it once. People love this T-shirt. We are still taught not to give pain meds for abdominal pain. Those are the types I'm scared to give it to. There is no evidence whatsoever that giving opiates or narcotics anyway to abdominal pain obscures the diagnosis, which is the biggest reason why we've been discouraged in the past from giving them. And there's actually a lot of data that says it helps clarify the diagnosis. Some people will have this wicked abdominal pain. It's just radiating out everywhere. They can't localize it, and they just know that it hurts. And then they get some pain medication, And it really, really helps. And now they're actually able to localize their pain and provide a much accurate description. The physician can zero in on where it is and, do, an exam where they test for, rebound tenderness and that sort of thing. And the narcotics really help with that. And so there is no reason to be afraid of giving narcotics to someone who's having abdominal pain. We get a lot of backlash for it where I'm at. Well, I can sleep just fine with backlash. As long as it's in your protocols, anyway. Always follow your protocols. My medical director said there's no major increase to bleeding with at least a single dose of Toradol. Okay, well, there you go. What's up, Avenger? What is up, Shogun of Brooklyn? Thank you. That flow through versus flow to explanation makes sense. Didn't ever think of surfactant washout. Well, that's the reason why people are self-peeping in CHF. You see it a little bit with COPD, but you see it a lot more with CHF. People just going like this, breathing like this. And the biggest thing, and this was what helped me early on in my career in differentiating people who were suffering from COPD or CHF, is the grunt. It's the people who are talking to you like this. Ugh, I'm having some trouble breathing. Ugh. That is a CHF grunt right there, and they are self-peeping. And the reason is because of that fluid that's getting from the capillaries into the alveoli is washing out the surfactant. And the surfactant gives your alveoli elasticity. It provides buoyancy to your alveoli. And so if you wash that surfactant out, they collapse if there's no air exchange. That's why premature babies that are born prematurely, need help, because I think it's 34 weeks that they start developing their surfactant fully. And so when they're born before that, they need some positive pressure, and they're also given an artificial form of surfactant. Finishing the evening, heading to bed up at 5. Hey, Charlie, thanks for stopping in, man. We'll do some more lives together, faux show. Bradycardia in hypothermic patients, PACE. I'm more concerned about their blood pressure than I am about their heart rate. Pacing a number is not necessary. And some of that can be protective. So, if they have a heart rate of 20 and a blood pressure of 60/40, let's get them some warm fluid first, as quickly as you can. But, if your patient's shitting the bed or just not improving, then yes, there shouldn't be a question you pace. But the hypothermia may actually interfere with the myocytes responding to that stimulation. That's why they're already not pacing on their own properly. Where did you get that t-shirt? That is where I got it. I'm going to have to make a video on where to get this t-shirt. The whole CCT gang is here, right? We are all, oh man, I think it was about a week ago, I was live with those guys, and Jenna Roxbury jumped on, and we had a wild live. I wasn't inviting anybody tonight because I really do value the interaction with the people who are watching the lives and answering the questions. And it's frustrating to watch comments fly by when someone else is on live and we're just talking to each other. So I intentionally did not invite anyone to go live tonight. Where can I get that t-shirt? I'm going to have to, you know what I'm going to have to do? I'm going to have to put us, either not wear a t-shirt during lives, or at least not wear this t-shirt. Or I'm going to have to put a sign here. I don't know if you can put a, like a graphic while you're live saying where you can get that t-shirt, but you can get it from Figure One. We support each other, smart people on here. Absolutely. And when other people are going live, I like to join in and see how they're doing. Although I have found that someone that doesn't have a large following and is just starting to break into lives, that someone like me or, Greg or someone else jumping in on their lives, really mind fucks them. and they have problems concentrating, and they get very, very intimidated. So you have to pick and choose who you're going to go live with. I listen to your lives loudly when I'm at the station, hoping people around get passive education. Oh, man, I appreciate that. Surface tension, yes. If you're trying to send me a message and you can't on TikTok, send it to me on Instagram. I don't have to follow you to get a message from you on Instagram. Broken tib fib and the Toradol works so much better than the narcs, but got cut off due to risks. Thank you. Love your scientific explanations and easy to understand. I appreciate that. And agreed on the monkey shoulder. Yep. Immortal Medic. This is a great idea. I love it. I didn't quite know what that's going on there. Mo Lives Faux Show. Put that on a t-shirt for a talk conference. Right. Dude, you're always serious. I get that all the time, that I'm so serious. And bring up great discussion. I'm curious, you got any funny stories? A lot of my funny stories really just have to do with like partner stuff. One of my favorite partners is a guy by the name of Stephen Fearon. We were partners for 2 years. We were actually a rare double medic truck that was able to stay together for that long. And the first day we worked together, we knew it was going to be like a partnership made in heaven. Hold on one second. Echo, living room fan on. Getting a little hot in here. Stephen and I were working together for the very first time, and we went to a call where it was like a site call. And so the police were there to clear the scene for us. And so we're just waiting with the fire department there so we could be cleared. And one of the guys comes out of the engine and comes over to the driver's side where I was just to talk to me. And so we're talking about it, and Stephen and I really didn't know each other at all. Like, we were still in that awkward phase of like, so what are you into, that sort of thing. And the window was open and the firefighter's standing right there, and he puts his hand right on the door right there where the window would be. And I hear Stephen just barely, this whisper in my right ear, just say, put your hand on his hand. And I immediately, I didn't just do it, I sold it. I took my hand and I just went like this in the most effeminate way I could. And just placed it on his hand. He snatched his hand away so fast. I have never seen anybody move that fast. And Stephen and I were cackling after it was all over. Because we knew right there and then that we were like two peas in a pod. We had the exact same sense of humor. And so we just always did stuff like that to each other. A running gag we had was we would have like those little salt and pepper packets that you get from fast food restaurants. And our game was you had to get somebody to take one from you on a call. And so you had to you couldn't just be stupid about it. But I remember being on a call where it was someone who had used some sort of substance, and the police were still talking to her in the bedroom, and so we were standing outside of the bedroom with the fire department waiting to go in there. I don't know why my funniest stories always have us waiting with the fire department, but it was a very serious scene. But I just took a little salt packet out and went up to the lieutenant and just said, the police said that she had this on her. I have no idea what it is, and handed it to him, and he took it, and he's like, and it was perfect until Stephen broke and started laughing. And we just had that sort of stuff every day. BR1 and T is in here. The Avenger is moving up in the world. Man, what am I missing? Who's here that I'm missing? Working the tail end of my 24, sitting at the table eating Oreos and listening to your live. Excellent. Man, I remember when I was younger, I could demolish a pack of Oreos in like 30 minutes. Somebody said the bottle is blocking the logo here. Figure 1. This seems pretentious. Unfortunately, I don't know what you're talking about, because some of these comments are backing up. So if you would like to tell me what you think is pretentious, I would be happy to accept that criticism, because I'm not above it, or at least defend this. Always love when you stop my lives. Oh, is that what happened? Like you were live and you were like wondering why nobody was there? That's funny. Wait, so you aren't banned? No. For anyone who is joining recently, I was stopped in a live about an hour ago, and it was saying that I was banned for a week because of bullying and harassment, which I wasn't engaged in anything like that. So I appealed it, and my privileges were restored almost immediately. I was bummed, man, because I love lives. This is such a great way to interact with the community, and it's really cool seeing the people who are familiar to me on at night and seeing the different crowd that's on in the morning, because I do go live in the mornings as well. Sometimes before work, if I get there early enough, or on my off days when I'm waking up with coffee. I will most likely be live tomorrow around 10 a.m. Best live we had was Charlie, you, and Jenny. Had a blast. That was a lot of fun. And hey, man, I like your lives. I think you do good work. The teaching is great. He's always serious because the data shows smiling decreases survival to discharge. That's awesome. That is awesome. Good night, Charlie. Heck yeah, a good partner can make or break you. Damn straight. There is nothing worse than getting up in the morning to go to work when you really just don't like working with your partner. There's just nothing worse than that. 12 hours in that claustrophobic environment with someone you don't get along with. Now, I've worked with people that I don't get along with who were fantastic at what they did, and that made it tolerable. But when they're also not very good at what they do and you don't get along with them, that's just terrible. Now, I'm a very, very patient individual, and I often get partners who are kind of like I'm the last rung on the ladder for them, to see if maybe I can fix them where somebody else hasn't. And I've had some partners that did better after riding with me, and I've had some partners where they were going to retire soon, but nobody could stand to work with them. And I've took one for the team and just let that partner sunset, even though I didn't like working with them. But every once in a while, I've gotten a partner that it doesn't matter how much I think I should be patient with them or how much I think I should be teaching them, we just don't get along. And that's unfortunate. Do you have a public email that I can reach you? Jimmy@emsavenger.com. Jimmy@emsavenger.com. Walter White. That's my favorite nickname that I'm getting right now. I need to do like some sort of spoof video, you know? Say my name. Say my name. That's my favorite show, by the way. Breaking Bad was the best show on TV. Pacing during CPR. Have you ever, and thoughts? I have, because that used to be part of the ACS algorithm to pace asystole and PEA. But it does not improve survival. And it can actually result in decreased survival because of the amount of time it takes to set up pacing. For some people, it may not take that long. You may be a badass and you may be able to set up pretty efficiently. But for some people, the process, of getting it dialed in and increasing the voltage and all that sort of stuff, people could be at that for a minute without capture. And if you're going to do that, you might as well just walk in and sit on someone's chest for a minute. So no, there's no benefit to pacing in cardiac arrest. Just like shocking asystole does not help. There's some subtlety to that, in that there is some evidence that some of the asystole we're seeing is actually very, very fine V-fib. And so it does help sometime with asystole to turn up the gain, but that doesn't mean that V-fib is going to respond to pacing. If you have very, very fine AFib, it probably is still not going to respond to either defibrillatory electricity or pacing electricity. Thoughts on ALS partners downgrading runs that are definitely BLS, but check enough ALS boxes? Well, they shouldn't be doing that. I am someone that borders a little bit more on keeping things ALS. Not that I never hand over calls to my EMT partner. But I tend to want a little bit more of cardiac monitoring and that sort of thing. Not to a ridiculous degree, but I mean, as long as the paradigm is that you are an ALS provider, you shouldn't be talking yourself down from ALS. I definitely think it's more beneficial to be conservative in that regard. And, if you're lazy and you don't want to take calls, instead of placing the patient at risk, just get out of the field. Had my first needle crike. I haven't done a needle crike, but I did do a surgical crike about 12 years ago. Had my first needle crike about a month ago. Talk about pucker factor. Thank God my soup was there. I probably would have done. I think it's a little bit easier. Well, you know what? I bet you that the apprehension is still the same. But yeah, sticking a needle in somebody's trachea is got to be wild. I mean, were you really able to ventilate them through that? I feel like that's kind of like Ralph Wiggum just going, there, I helped. The needle crike. How did that work out? I really want to know. Your opinion, ventricular standstill has P waves, but no pulse. Sometimes they call that P wave asystole. Pace or treat like PEA. I would pace that immediately. What are your thoughts on limiting the hours providers are allowed to work at one time? I mean, it depends on how busy you are. There's plenty of services. Like I worked for a service in North Carolina. It was kind of feast or famine, and it was a beach county. So in the summertime, we were just gone all day. But in the wintertime, I could go 2 days at some of those stations without a call. And so there's no reason why you couldn't work 48 hours or more in a row, because you're basically just sitting around and sleeping all the time. But if you're working for a service where you're staying up 24 hours straight, then there has to be a law that not only protects the providers from harming the employees that way, but the employees also need to be protected from themselves. Don't say fine VFib. Okay, I will not do that anymore. Low voltage VFib, how about that? ALS until proven otherwise. I mean, pretty much. Now, there are some patients that I'll put the patient on the monitor and check everything to confirm what I already basically know to be true, that this is a BLS call. If there's any sort, if there's any sort of wavering, put them on the monitor real quick and take a look at it. Doesn't mean you can't take them off the monitor and give it to your BLS partner. Nothing wrong with that. On my current knowledge, RNT can result in VTAC. So what would that equivalent be for AFib? But what? I mean, what? Like, you still have to, if you're going to cardiovert them, you still have to synchronize, if that's what you're talking about, to make sure that you don't cardiovert on the relative refractory period. So I'm not sure what that question's about. Can you ask that question differently? I rarely turned over a call to a basic. I've fired more paramedics for doing so. Well, I'm assuming that you fired them because they turned over a patient that needed more than BLS care, right? You're not crossing two different processes. Well, I'm not sure where you're starting from. So RNT does not result in VTAC. VTAC is something that you would cardiovert, and if you don't synchronize, at least in someone with VTAC with a pulse, if you don't synchronize, then you could actually defibrillate in the wrong place, and you could put that VTAC into ventricular fibrillation. That's what the R on T is. But VTAC would be something that we would be cardioverting, not something that we would be worrying about something deteriorating into VTAC. And the reason why we don't sync in pulseless VTAC is a lot of monitors can't sync with only the pads on. They actually have to have the limb leads on, and it also takes a lot of time. And so the hands-off time is probably more harmful to the patient than syncing up is beneficial, if that makes sense. Can you breathe through a 14? Absolutely not. Was a cardiac arrest with massive airway occlusion. The surgical airway I did was so bloody. Oh my God. But it got her breathing again, saved her life. Was a cardiac arrest with massive airway occlusion. Couldn't get her all the way out with McGill's. Gotcha. So, you know, I'm somebody who gets a lot of people who are newer to the field, and I get people who are also wanting to learn, and so I'm not stingy with handing calls to my partners. I want them to get their hands on things, and I want them to experience things, and so I try to get their hands on as much stuff as possible and let them. In Georgia we call it teching calls. You're the tech on the call. Excuse me. So I try to get them teching as many calls as possible, or as many calls as they want anyway. I always give them agency. You know, if we're getting one BLS call after another, you know, I want them to have a break too. So, you know, I'm not just going to make them or let them tech all day unless they want to. But I definitely want to get their hands on stuff, you know. And so, you know, I'll do some ALS diagnostics as a rule out. But if there's no ALS concerns, I want to get these people as many reps as possible. Tube got occluded. Our needle crikes, we have an oxygen delivery tool that forces air in. Got a bug. Be safe out there, bro. You be safe out there, too. Hey, thanks for tuning in, man. WPW with AFib will kill someone pretty quick if that's what they meant. I don't think they did. I think that there's a little bit of confusion there. But yes, WTP. In fact, if you've heard the dogma that you can't give adenosine to someone with WPW, that's actually nonsense. The whole thing revolves around WPW with AFib, because, you know, the atria, when they're in AFib, they have that fibrillatory pattern. And if you knock out the AV node with adenosine, then you're left with that bypass tract that goes from the atria to the ventricle, and that bypass tract can carry that fibrillatory pattern down to the ventricles. That's the harm in giving adenosine to somebody in WPW. So outside of that, if someone has WPW and they're not in AFib, give them the adenosine. It is not going to harm them. I've always hated needle crikes. I made my medic students breathe through a 14-gauge needle. I think that's a useful exercise, but if all your service has is needle crike, I mean, what are they going to do? In Georgia, that's all we can do is needle crike. Not medical, but opinion on professionalism or lack thereof in EMS. The Venn diagram of EMS personnel who complain they get no respect, and the EMS personnel who don't tie their boots and let their pants lap up on the top of their boots is a circle. If you want to be treated with respect, and if you want to be treated like a professional, then respect yourself and act and look like a professional. You know, in the garbage service, people dress better or take care of their uniforms better than they do in EMS. And, you know, think of the people that work for your system, that are your support, the people that work in billing, the people that work at desks, the people that work in training. You know, they don't walk into the building with their shirts untucked and their shoes untied and just walk into a room full of people and unzip their pants and start tucking in their shirt. They don't walk out of the building wearing their suits, and their dresses and stuff and start unbuttoning their blouse and pulling their shirt out and untying their shoes. But yet they're not very visible. Nobody would ever know if they walked into a gas station dressed like that they worked for your ambulance service or your local EMS service. But we have EMT and paramedic after EMT and paramedic that thinks that it's cool to be undressed on the job. And you're the one who's actually representing your service. You're the face of the service. I don't get it at all, and I hate it. And it's the one thing, I try not to be overly critical of people and overly critical of individuals in general. I try to be a little bit uplifting, and I'll do some call-outs every once in a while. But this is one thing where I don't hold back. You just have to respect the profession better than that. You're not respecting yourself when you dress like that, and you're not respecting me when you dress like that. I've been trained on surgical cracks, are definitely better. Well, absolutely. When you can actually get an entire ET tube through that space, that's for sure better. Just make sure that you're using a bougie on that. Poor hygiene, poor appearance, smoking and dipping constantly. The smoking paramedic is very, very problematic as far as image goes. Dumbing down a patient because you don't want to be on the bag was immediate termination. Well, I mean, that's not really consistent with just culture, I mean, are you giving them an opportunity to correct that, or is this like repeat offenders? Oh, I get it. Okay, on the bag, because I didn't follow that. The bag means that they're teching. You know what I can't get over is the New Jersey EMS personnel that calls are called jobs. But that is very New Jersey. I'm originally from New Jersey, and that is a very New Jersey thing. Do you have a preferred pre-med for pacing or cardioversion? No, ketamine, fentanyl, midazolam are the usual choices. If we have time, then I would prefer to use ketamine. Although, there's some people that need to be cardioverted and they're actually hypertensive, but they still need to be cardioverted. And I might go Versed there simply because it's going to wear off faster than the fentanyl. And they may not need a catecholamine burst from the ketamine as well. But in most cases, my preferred go-to anytime I want to do sedation is going to be fentanyl. But in the case where somebody has a fast heart rate and they're hypertensive, Versed is still a reasonable choice. I don't think I would go with fentanyl because they're going to remember that. The one thing I like both about Versed and ketamine, I mean, with ketamine, they're fully sedated, so, they're not really aware of it. With Versed, they may not be fully sedated, but they have that retrograde amnesia, so they're not going to remember it. They'll forget it immediately. So, I mean, Versed is still a good choice there. But, if they're just shitting the bed, then nothing. I'm just going to cardiovert them. It's 1 second in time and they'll be fine afterwards. And I'm not unsympathetic to the pain that's causing them, but, sometimes they just need immediate cardioversion. Oh, I almost missed this. I just started as an EMT for the first time. Any advice? Yes, you need to surround yourself with people who are going to help you be better. So when you come across that person that is a chronic complainer, don't hang out with them. Don't be partnered with them. When you hang out with those toxic personalities, those people that are just capable of a massive transfer of negative energy, get away from those people. And then ask around, who are the really smart people here who I can learn from? Go become those people's friends. And then get to know the doctors and the nurses and the facilities you're going to be transporting to most often. That's the best thing that you can do for yourself right there. A rising tide lifts all boats. I was reading today that to never give lactated ringers in a crush injury because it raises hyperkalemia. Well, it's a balanced fluid, so it really doesn't. And it takes a long time to raise your serum potassium level. You don't just dump potassium in there and just see an immediate rise. So I don't think that really holds up under I don't think that holds up under scrutiny. And there's a reason why when people in DKA who are very, very hyperkalemic, their potassium levels are very, very high. And that's relatively speaking, they as a whole, they have actually lost potassium in the process of trying to offload glucose through their urine. But when you start getting acidotic, your hydrogen ions start to get very, very asshole-ish. And they burst into your cells and they kick the potassium out. And that raises your serum, that causes relative hyperkalemia. But, one of the first things that they do when you get to the hospital in DKA is they start giving you potassium. And that's because of how long it takes for your serum potassium levels to rise. So by the time that potassium starts to kick in, and they may have given you tablets as well, by the time that kicks in, your potassium is starting to work its way back into the cells. So lactated ringers should not cause immediate solvent drag like that. You're welcome for the time. Thank you for being here. People keep saying thanks for the time. Thank you for your time. Thanks for being a part of this. This is cool. I've always aspired to be a creator, a content creator, and to somehow, use what I've learned to help other people. And I get something out of that. Not for my ego, but just knowing that I've done something to be helpful to society. And so the people that are watching help me achieve that goal. And so I'm very appreciative of all of you. Got your results not too long ago and passed the registry. Awesome. Awesome work. Did you take the new registry test? Did you get the new questions? Have you ever seen a paramedic use a PR-24 on the back of someone's neck while they are prone? I don't know what that means. Lactated ringers does not cause hyperkalemia. Yeah, that's what I'm saying. It's a balanced fluid, and balanced fluids don't really work like that. I've been cardioverted twice. Strongly recommend etomidate. Etomidate that's a good one. A lot of people don't carry etomidate who don't RSI, and there are a lot of services and even entire states that don't RSI. Doesn't ACLS state stable versus unstable is on BP alone? Well, changes in mental status as well too. But ACLS is essentially a algorithm for dummies. It is a guide, but you have to make a clinical determination of what that patient needs. How often do you use an OPA or MPA in the field for an unconscious patient? Fairly often, and one of the biggest reasons why I use it is because I want my partners to be able to practice that skill. Not necessarily an OPA. I don't use that as much because there's not many people. A lot of people who are unconscious still have that gag reflex, but an NPA for sure. That's a harmless intervention, and if you have snoring respirations or they're not perfusing very well, that should be the first thing you do. Now, I'm not dogmatic about it. I don't think people who are unresponsive should empirically have airway adjuncts placed, but fairly frequently if they're actually unconscious and showing some indications of airway obstruction. Normal saline does by promoting acidosis. Yes, it does. Normal saline increases the strong ion difference and causes hyperkalemic acidosis. Lactated ringers does not promote hyperkalemia. That's correct. Anyone getting a BVM needs an adjunct. Sure, absolutely. What do you think if people say that you can't call a STEMI with a left bundle branch block? Well, I say that they are wrong, and you should fix yourself. Scarbosis criteria was adopted this very year as consistent with STEMI guidelines. So if you think that, then you just aren't educated enough. So STEMI equivalents, as of this year, are not just your traditional STEMI criteria, but Scarbosa criteria, De Winter's T waves, and hyperacute T waves. Now, hyperacute T waves, there's a little bit of subtlety to what that actually means, but those three things are STEMI equivalents. I've got a medic trainee who's only experienced, and that's also, the Scarbosa is also applicable to pacemaker rhythm, ventricular pacemaker. I've got a medic trainee who's only experienced his Army. He barely talks to patients, advice as an FTO. Oh, man. Those are people who just aren't curious. And when people ask me what makes a good medic, I always rely on two things: curiosity and compassion. I'm not going to talk about the compassion part right now, but you have to have a certain amount of curiosity. Well, compassion kind of feeds into that, though. If you can't relate to your patient or appreciate their situation, you certainly aren't going to go out of your way to find out what's going on. But you have to be intensely curious. You have to want to crack this egg and solve this mystery. And if you don't, what did you get into this for? What did you think that you were going to be doing? You just have to be a better provider than that. You have to ask and just keep asking questions until either you're satisfied or you just have to acknowledge that nothing else is going to reveal what's going on here except for, in-hospital diagnostics. But some people just haven't figured out how to approach an assessment. And we're taught in EMT school and paramedic school the OPQ-RST assessment tool for focused assessments. And I think there's some people that are resistant to having an assessment tool like that, like gift wrapped for them. They just have an aversion to that, and so they want to figure it out on their own, and some people have it. But some people need to be reminded that OPQ-RST is a perfect assessment tool. It really is. And it really can't be improved upon. And if you use it appropriately, you can start figuring out your own processes around that and woven through that. But it's a fantastic assessment tool. So start encouraging people who aren't talking very much to fall back onto OPQ-RST and sample and see if it doesn't stimulate their assessment skills. That's right, you can with the modified Scarbosa criteria. Good night, man, to you as well. Thanks for hanging out, man. Appreciate you. I'm sorry, did I see your cup says Harry Potter? I took my son to Universal Studios about 5 years ago, and they have the whole Harry Potter thing there. This was the only thing I bought myself. The Deathly Hallows. Where I am from, it is taught as the doctors say it can't be done. Are you talking about Scarbosa criteria? Those doctors need to go back and educate themselves. I don't know how you can be an ER doc or a cardiologist right now and not understand Scarbosa's criteria. It doesn't always, you won't always see Scarbosa criteria, but when you do, it's very trustworthy. ACLS is bare minimum competency for people who don't routinely practice critical care. Correct. Now, I will say that you shouldn't, on a cardiac arrest of suspected cardiac origin, ACLS is pretty good. I mean, they still are, emphasizing the epi, but outside of that, they've done a very good job of reducing running a code to the bare essentials that you need. And I think that when you think as a critical care provider on cardiac arrests, that you end up getting in the way of a quality resuscitation. I know critical care providers who want to start getting fancy with minute volume and that sort of stuff and offloading CO2 and all these sort of things, and they just start compromising the quality of compressions and start compromising the compression fraction and causing problems with intrathoracic pressure, and they it just, you should think like BLS on cardiac arrest. There's a reason why survival is higher with BLS run calls rather than ALS run calls. Lactated ringers would actually help hyperkalemia, if I remember correctly. It really depends on how much you're getting. You're the only EMS TikToker who I recommend to people asking where to find good info, by the way. Man, thank you so much, man. I'm just humbled. I'm humbled by that. Thank you. Thank you. I am drinking Lagavulin 8-year. What's the best way to handle a green medic whose ego is through the roof? Throw them to the wolves. You know, there's a proverb that says it's better to keep your mouth shut and be suspected a fool rather than to open your mouth and confirm it. You know, just let them hang themselves. That's really the only way you can do it, unless you're the sort of person that has the sort of personality that can get somebody's attention and teach them. But outside of that, often the best way to handle it is to let them humble themselves or embarrass themselves somehow. A lot of people will say that's a lack of compassion or a lack of teaching or a lack of understanding. But some people can only teach themselves by doing the wrong thing. That doesn't mean let them do something wrong that's harmful to patients, but sample OPQRST on every patient. Let it become muscle memory. Yeah. And on focus assessments like abdominal pain and chest pain, I literally go letter for letter through OPQRST. There's no reason to reinvent the wheel. I spy with my little eye a Jenna Roxbury. Stephen Smith ECG blog is a great resource. Yes, not just for Scarbosa, but for anything cardiac or for 12-lead interpretation. If you're not following Stephen Smith's ECG blog, you are missing some of the best ECG content out there. And you can find him on Facebook and you can find him on Twitter. And whatever that RSS feed is that lets you know that there's a new blog out if you don't have either of those. The reason I asked about that PR24 is I had to arrest a paramedic for murder doing that. I missed the explanation. What is a PR24? He also has his online textbook there for free, yes. And his partner is Ken Grauer, who is also an expert at ECGs, and they often now critique each other's interpretations on that blog. Why the F does a paramedic have a police baton? Oh, is that what a PR24 is? Yes, that person should be arrested, absolutely. No EMS TikToker speaks as well as you do and displays the qualities we need to encourage in the field. You guys are making me cry, man. Why the 8-year instead of 16? Because it's cheaper. I have a 16 in my cabinet that I'm waiting to become a 20-year. It's actually a 16-year that is now 18 and a half years old, and I want it to become a 20-year, and I'm going to crack it then. But I have a lot of different scotches and a lot of different ryes, a lot of different bourbons and stuff like that, And I just kind of, it just depends on what mood I'm in. But, 8-year is a very affordable Lagavulin that is still a high-quality single malt scotch, so... Good to see you again, brother. Hope you've been well. Whiskey on the rocks tonight, so cheers. Cheers to you. I don't like doing it on the rocks because I don't like diluting the flavor. A police baton. Okay. And he used that on a patient? That's terrible. That's absolutely terrible. I hate to hear that. I'm finally caught up in the questions. That took a while. This has been a good live. I think I came on about 9:30, quarter to 10. I had my brief 5-minute vacation when I was suspended temporarily. And usually after about an hour, things start winding down, but there's still about 50 people hanging around, so that's cool. I'm sipping a Maker's Mark 46 myself. Maker's Mark makes a good whiskey. I like Maker's Mark cask strength. I love the alcohol burn in that. His third partner is Pendle Myers. I've never heard that name before. Who is championing his effort to forward the OMI paradigm. Big fan of the OMI paradigm. And so, for anyone who doesn't know, Stephen Smith, who is one of the most preeminent electrocardiophysiologists in the U.S., meaning the interpretation of EKGs in relation to, pathophysiological cardiology, one of the most preeminent interpreters in the U.S. And he is the author of what's called the OMI Manifesto. And so what he is advocating for is that instead of thinking about STEMI being the paradigm which we send people to the cath lab for, or activating the cath lab for, that we look at it differently. And that's because STEMI misses a lot of conditions where somebody needs immediate catheterization, but it doesn't show up as a STEMI. And so he advocates looking at things through this lens. Occlusive myocardial infarction, which is when there's actually a lesion there, or non-occlusive myocardial infarction, such as when somebody's experiencing a vasospastic myocardial infarction. And you also often see people who have some sort of massive sympathetic response to things like cocaine and methamphetamine, that they experience such profound vasoconstriction that they start infarcting, which, if you're wondering, you can start treating that immediately by administering midazolam. Ever tried horse soldier? I haven't. How do you handle a DO at an urgent care clinic that is ordering improper things for a patient? There's not much I can do in the clinical environment other than having a polite conversation. But I don't like having confrontations with people. You have to be able to read the room and ask yourself, what is the likely outcome of this conversation and this confrontation? And I have definitely encountered physicians that were open to a conversation. In fact, I did a critical care call for somebody that had a head bleed who was intubated. They needed to go to an outlying hospital, to a hospital that had a neuro unit. And that patient was starting to buck the tube. And I wanted to give them ketamine to help them get back down. And the ER physician didn't want to do that because he believed that ketamine was associated with increased ICP, which is not true. That is a myth that was dispelled over and over again, and it's based on some very outdated data. And I presented him a very reasoned explanation as to why this was not true. So he went and made a phone call to somebody else and came back and said, I talked to somebody who I trust and would know about that, and he says that you're right, so let's go ahead and give him some ketamine. And that was a great way of handling that. But I felt like, just based on his interactions with me, that he would be open to that conversation. But there's definitely physicians and nurses, when you talk to them, you know that they are a glass that is already full. And in that case, obviously you don't do anything that would hurt the patient, but sometimes you just take the patient, Hold on. Sorry, I must have triggered my Amazon device. But in that case, I just get them in the truck, and then I don't do the thing, or I do the thing that I'm supposed to do, and nobody's ever the wiser. And I never, I'm never like lying or trying to get away with anything. I document everything. Does your EMS agency participate in the AA Mission Lifeline? Like, are they reporting all their data to CARES and all that sort of stuff? Thank you so much for all of your content. Currently in the Fire Academy and then back to medic school. Well, I wish you luck in both of those endeavors. Study hard. He gave the aspirin before I could get the patient to the truck. What am I missing here? What was wrong with giving that patient aspirin? How busy is my agency? When I go in service in the morning, I'm going to get a call. And then after I transport that patient to go in service at the hospital, I'm going to get a call. And then after I run that call and I go in service at the hospital, I'm going to get a call. That's how busy my agency is. Are you a Bob Page fan? I mean, I went through the Bob Page class when Bob Page was in vogue, you know, like almost around 15 years ago was when I think that Bob Page peaked, it was called Bob Page Multi-Lead Medic. But, you know, he wouldn't be the first name off my lips right now as far as, like, you know, people who are setting the standard in EKG interpretation and in easily understandable cardiology education. You know, there's educators now that have kind of come out that, you know, are doing the same thing, but he was definitely, or is definitely, a pioneer, and he led the way for a lot of other people to do ground level education. Tim Phelan is somebody also kind of from the Bob Page era as well, but he still goes around and does stuff. I don't know if Bob Page does or not, but Tim Phelan, you know, is fantastic. Tom Boothele, you should follow him on social media. He's an ECG guru as well. And Amal Mattu. If you're not following Amal Mattu, then you don't know enough about cardiology, period. Yes, the Bob Page capnography class is actually very good and still very, very current. And you can't even improve on that. It was a fantastic course. I definitely understand that we are nonstop in Detroit. Oof, what a place to be a medic. You guys must get run hard, rode hard and hung up wet. How does nitro relieve angina? It is not analgesic. It is something I haven't quite grasped. So you have a chemical in your vessels, in your blood vessels, called nitric oxide. And nitric oxide is what is responsible, or partly responsible, because, like, you know, your alpha cells also are. But nitric oxide plays a huge role in vasodilation. And so when you're given nitroglycerin, which is analog of nitrogen, it interacts with nitric, which is an analog of nitrogen. It interacts with nitric oxide, and so it promotes vasodilation. And when you have that vasodilation, you have improved blood flow, and so it relieves that ischemia, and so that chest pain is relieved. I love the shirt. I have the same one in blue. That's awesome. You're the only other person I know that has one. Much respect for what you do. I'm on my way out in about 6 months, 29 years in. Well, thank you for your service, Life Dog. I appreciate you, man. Hey, man, glad to see you on. Well, thank you, Remote Medic. I'm glad to see you. My agency transports 180,000 calls a year, busiest EMS agency in Florida. I think we were at 220,000 this year. The chest pain is primarily from lactic acid buildup. Fix that, fix the pain. How does one correct lactic acid buildup in the presence of angina? Hey brother, I just survived 13 hours in the ED. Hope you're doing well. I am doing well. I hope that you're doing well and that you resolve your burnout very, very soon. I love ESO. It's very user-friendly. Great job. You've gone live for 90 minutes. Don't forget to take a break. Well, make up your mind, TikTok. Do you want me on here or not? You already kicked me off once. I'll be taking a break when this is done. Right. Lactic acid is from the ischemia. So you never treat lactic acid. Lactic acid is just a marker of another problem. It's just like in sepsis. You don't target lactic acid. So you relieve the ischemia, and you relieve the ischemia by improving blood flow. We transported around 192,000 last year. That's a lot. We had 220,000 for calls of service, but it's 180,000 transports. Yeah, I'd be curious to know what ours is. I mean, yesterday I had like 7 cancellations. I think we use ESO. I'm pretty sure that we do. We did 500 runs last year. I mean, what you're saying, though, is that you're a smaller service. What major city are you near? Not to try and find your location. I don't mind giving away my location. I work in Cobb County, Georgia. Run 911 in Cobb County, Georgia. I just don't mention my company specifically. But, if somebody happens to identify my company and ask me if I work for them, I definitely will say yes. Rural EMS, 1,200 with 1 MICU. Some people have tried to issue a little bit of caution with me about my TikToks, and even when sometimes I'll go live at work when it's slow, or I'll record a video in uniform even though I obscure the name. Just so you know, my company is very well aware of my TikTok channel, and I have repeatedly checked in with the people who would have concerns if there would be concerns, and there are no problems there. I am not in Pennsylvania, although my parents do live in Philadelphia. I lived in Philadelphia for a very, very brief time. And I did not enjoy it. I actually really, really like Philadelphia as a city because I really like the old colonial parts and like going to Independence Hall and stuff like that, but I wouldn't want to live there. Oh. I'm back to work tomorrow, and I haven't worked since New Year's. It feels weird. I work urban EMS. Yeah, I was out for 3 weeks this month because of COVID, and it felt weird coming back. My agency only averaged about $45K a year, but rural EMS is a bit of a different beast. Keep in mind, too, my agency does a lot of interfacility. We have critical care trucks and non-emergency trucks, wheelchair vans, and that sort of thing. Crazy, you're in Cobb. I was born in Lithia Springs, lived in Marietta and Douglasville. Yep. And I really like the area. I worked at our district ER for 7 years, burned out and had to leave. Somehow landed a cool telejob. That's cool. A health remote position. Somebody teased me with a position a couple weeks ago that was intriguing. And if anyone from my company is watching, I am not considering it at all. And I'm very happy where I am. But, I listened to what they had to say. But it was 7 days on and 7 days off. 7 12-hour shifts on and 7 off. No, thank you. I work 3 14s in a row. Well, somebody just asked me, does your agency do 12s or 24s? It depends. In Cobb County, where we are very, very busy, we do 12s. But we also handle 911 for some rural counties, and they do 24s out there. We also have some 10-hour shifts, some 8-hour shifts, and some 14-hour shifts. I do 3 14s in a row, and that's about as much as I can handle. But I love my 4 days off in a row. I'm just about to start P3 of medic school. Well, I mean, the advice would be something you would have wanted starting medic school, which is, well, you can still do it though. Stay ahead of your reading. Do multiple passes at the chapter that you're going over. Read before class, read the chapter again before class, and have one read of the chapter immediately after the class. And then that third read, take a highlighter and just break up the information. You don't have to cram or try to memorize anything. But if you get 3 passes at that information, and in one of those passes you do some highlighting, you're going to do fantastic. God, I miss 24s. liked 24s where we actually got some sleep, but towards the end of when I was on 24s, we were up for 24 hours, and that was miserable. Just implemented epi during codes to 0.1 milligrams to 0.5 milligrams. 1 minute wait time per each, 0.1 milligram. Very happy. That's an interesting strategy. Why not just an epi drip? But still, I think that's more progressive than cyclical rounds of high-dose epi. I used to do 7 on, 7 off nights. It was super awful. Yeah, by your third day, if you're doing 12s or whatever, you're tired. On my third day of 14s, I'm running at about 60%. So on day 7, there's no way that you're just not impaired. There's just no way. I'd love to do 24s instead of 72s and 96s and 168s. I get confused on what to do on my days off. Yeah. Any agency that allows medics to be awake for 24 hours should be held liable for any mistakes made. Absolutely. We do 48 96s. That's fantastic. That's a great schedule. And I'm assuming that you guys get adequate rest in that schedule. I can go live now. I immediately appealed it, and they overruled it. They said they did not find any bullying or harassing behavior. I need to go take that video down. $24.72s here. That's awesome. That's a great schedule. Where I worked in North Carolina, I was on a California swing, and there was a local fire service that did 24.72s. And they had very little turnover because people loved that schedule. And they had a position open, and the chief tried to recruit me. And I really wanted that. That sounded fantastic because they did 24.72s. And then like every 3 weeks, you got like 10 days off in a row, something like that. And the only caveat was that I would have to get like the most basic fire certification that you could get. And they assured me that, you know, that if there was a fire scene, that it was highly unlikely that I would do anything other than assist in rehab. But I started thinking about it, you know, and I just felt like I was going to be disrespecting the firefighters who were putting everything they had into being a good firefighter. And that having an EMS tourist working for them who didn't take firefighting seriously just was, I just felt like it was disrespectful. And so it meant I just turned it down. I just didn't feel like it was appropriate because I don't want to be a firefighter at all. Oh, my neck's starting to get stiff from sitting like this. I feel the same way. Don't put me anywhere near a burning building. No, thank you. And that's no disrespect to firefighters. In fact, it makes me have more respect for them because they want to do that. You know, and I want to support them in that endeavor, and I don't want to be someone that is disrespecting that commitment. I wouldn't feel bad. Seems most firefighters don't want to do EMS. Yeah, I think that's kind of the whole, like, fire medic not wanting to be a medic or firefighter EMT not wanting to be an MT is kind of low-hanging fruit. There are plenty of, maybe this isn't as true for EMS-only EMTs, but for EMS-only paramedics, there are a lot of bad paramedics out there that are not firefighters, and they only got their paramedic because they wanted to get paid more than an EMT. And I'm not sure. I have seen plenty of fantastic EMTs and paramedics that are firefighters, and I've definitely seen my share of shitty EMTs and paramedics who only work EMS. Do you work for the company initials MA? Yes, I do. Vaguely remember the private company doing stuff at Grady. Yeah, I do. We have a big footprint here. Coming from a firefighter who is in medic school, it's all about what department you are working for. I can tell you that the firefighters where I work, Cobb County Fire Department, the fire medics there, I think they are more than competent. And some of them are some of the best paramedics that I've ever met. And you know what a lot of them do is once they get their medic, a lot of them actually end up working part-time for a local ambulance service so they can get that transport experience. Because ultimately, I think that's what gimps a lot of fire medics. It's not that they don't have a commitment to it. It's that they don't see the back end of calls. So they don't get their confirmation, they don't get their diagnosis confirmed, or they don't have a physician right up in their face saying, no, 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 that's not what this is. And a lot of them actually take paramedic positions in the local ED as well. So I think they do a good job of trying to get the experience they need to be competent paramedics in a situation where they're not transporting. The fire medics here, they have more stuff than even some of the private services here. They're getting like neosynephrine, and I think they're even going to get whole blood. What are your thoughts of using, I can barely read that, Offermev pre-hospital for analgesia and fever? I don't even know what that is. Fire is coddled. Oh, I'm not going to get into that. I'm not going to touch that. Oh, our firefighters definitely want to innovate. But you know what? I think our firefighters are even more disciplined when it comes to intubation than our transporting medics. I think our transporting medics will avoid dropping an eye gel so they can take 5 passes at an intubation, where in a code, a firefighter is happy to drop an eye gel, and that makes me all warm and fuzzy inside. Because on a cardiac arrest, you shouldn't get caught up in intubation. You just want to get that advanced airway in. Oh, Offermev is the IV acetaminophen. I've heard it referred to as paracetamol. Is that the same thing? But I think that's fine. There's definitely some people who are febrile who don't need something PO. If it's a difficult airway, they can get an eye gel. The ED can worry about a tube later. Exactly. Hello from the medic, in all caps. Hello back to you. I was going to duck out soon, but we still got like 40 people hanging out, so I'll try to hang out a little bit more. I want oxygenation. I don't care how it happens. Yeah, the only time that I might prioritize a tube in cardiac arrest is if it was a cardiac arrest from respiratory means. And then maybe I might think about getting a tube. And, I mean, we use the King Vision, and I'm going to get that tube in there just like that. But still, I don't get hyper-focused on that tube. I always preach, don't fall in love with your interventions. Because then you're going to find reasons to perform those interventions when it's not really that justifiable. I just used Offermev on an IV pump for an interfacility transport the other day for a girl with appendicitis. That sounds fantastic. Having something that is a pain reliever and an anti-inflammatory is very beneficial. Is it common to have basics dropping combi tubes? I hope that we don't have anybody commonly dropping combi tubes. The proper way to drop a combi tube is to drop it in the trash. But is it common to have basics dropping combi tubes, iGels, and Kings, or are those considered advanced? It depends on where you are. Anybody can drop an iGel here. You stay safe as well there, Chris Burkhart. Thanks for being here, man. Appreciate you. West Virginia, 24-hour shift recliner babysitting. Awesome. In Wisconsin, that's an EMR skill. That's great. Yeah, I've heard that about... I've never heard it called Offermev. I've heard it called paracetamol. Maybe that's what they call it in the UK. But that's what I've heard, is that IV acetaminophen is very expensive. King Vision made me better at intubating. Yeah, video laryngoscopy has made everyone better at intubating. Combi tubes should die. Well, for as many people as they've killed, I think that's true. Lido is a common analgesic in our ER. an analgesic for what? For anything? Like just as general analgesia? My protocol has IV Tylenol for pain only. Pyrexic sepsis patients have pain, though. That's true. I've used Ofremeb and Toradol for hip fractures over opioids with impressive results. Well, yeah, I mean, those things are targeted more to that sort of pain, anti-inflammatories. I have a question for those who are watching. How many of you people actually prefer in a fracture, in a simple fracture, to do a pillow splint where you can keep the bone ends away from each other rather than splinting and attempting an alignment with the bones? My preference, in most cases, in simple fractures, is to keep them in a comfortable position where we're not drawing those bone ends together. Because I think that these splints that are trying to realign the extremities are responsible for an awful lot of pain from those bone ends hitting each other. I would much rather do a position of comfort in a pillow splint, and I think I'm going to do a video on that too. Well, we got some fans of the position of comfort here. I prefer whatever gives my patient the least pain. Well, that's the best answer right there. Sure. But it's also, you're also dodging the question. That's like saying, do you think 2 plus 3 equals 4? Or excuse me, do you think 2 plus 3 equals 5 or 3 plus 2 equals 5? And you saying I'm for whatever equals 5. That's a non-answer. When they get to the ED, when they can conscious sedate and put their bones where they're supposed to be. That's right. That's right. And trust me, we enjoy it. Yeah. You know what my favorite thing is when they come in with a dislocation. And this happens more so, I think, with pediatrics than adults. But when the doctor just walks in there and says, hey, I'm Dr. such and such, you know, and just sneaks up on them and just reduces that dislocation. I love that. I think there are more papers written about the combi tube than there are survivors. Yeah. Oh, Captain Glucagon, your interaction with my stuff on when I'm checking all my notifications is fantastic. Thank you. Now, if it's pulseless, it would be a little bit different. Well, absolutely. I mean, that's a whole different scenario, though. But if I have a simple fracture, you know, other than femur fracture, which I do want to use a traction splint on, but a simple fracture, I would rather just keep those bone ends apart. You know, that lining, the lining of the bone, which is called the periosteum, has the most sensitive pain sensors in the body. And so when they touch each other, that's the worst pain that you're going to feel. And so I don't understand why you would want to bring them that close to each other. And I always give pain meds before moving them as possible. Absolutely. One of my first priorities, you know, with someone who's experienced some sort of trauma or is experiencing any acute, well, I don't even want to say acute, I mean, because that kind of limits the people. But if someone's in pain and moving them is going to cause them more pain, then pain medication at that point is a form of stabilization. And as far as I'm concerned, it's a necessary and required intervention at that point. And you should definitely be providing that analgesic before you move them. I've not used a traction splint on a child with a femur fracture because he was comfortable. Wrong? No, I don't think that's necessarily wrong. The problem with a femur fracture is that there's more muscle tension on that fracture than there is in any other fracture in the body. That your muscles are desperately trying to make sense of why they've lost tension. And so they may not be in pain now, but in 5 minutes, those muscles may start contracting. And so that's why it's probably a good idea to always use a traction splint with a femur fracture. Thanks, buddy. You're spot on as well. Oh. And you're one of the reasons why I usually hold back when people start asking questions or getting argumentative in videos, because I value the community itself coming together and providing kind of confirmation or adding color commentary to that. I really value that rather than me being the police and gatekeeper of that content. And so when somebody solid like yourself gets in there and provides some other answers, I feel like that's a powerful thing, and I really, really like and appreciate that. I don't want to needlessly give pain meds, but when I see a reason, I'm not going to hesitate. Well, no one wants to needlessly give any medication. But a pain medication is the one thing where if you don't give it to someone who really needed it, then you're actually causing your patient harm. And we're in the business of harm reduction. And I can sleep just fine knowing that somebody got 50 of fentanyl for, for maybe reasons that other people would find unjustifiable. I can sleep very well at night knowing that. But there have been some patients where I kind of was waffling back and forth and didn't. And after the call, I was like, why didn't I do that? Why didn't I do that? And the reasons why are usually I didn't want an awkward conversation with a doctor over the phone or something like that, or as much as I may try to avoid getting into the game of whether or not a patient is trying to get over on me, you can't help but sometimes consider whether a patient is selling you a bill of goods to try to get pain medications. And you know what? It's just better overall to give it. If there's a question as to whether or not to give it, if you're fighting with yourself, then the only loser is the patient. Laziness makes for an inadequate provider. Absolutely. And I'm not calling that other person lazy. There's no context to that. And by all rights, that statement means that he's giving it when it's needed. Funny you should say that. I gave 50 to 2 different patients last night. I hate wasting the half. Yeah, I hate it too. But you have to do that with ketamine all the time. We carry it in 5 milliliter vials, 100 milligrams per milliliter. And half the time we're going to be throwing out, 4 milliliters. How to get through to those EMTs. Hold on a second. Things are still going good here, so let's pour just a little bit more and buckle in. Not too much. I can hold my liquor, but I will spring awake at like 3 in the morning and not be able to go back to sleep. How to get through to those EMTs that sit behind the head and don't talk except to ask questions for the PCR? That's a good question. How do you get through to them? You have to model that, The best way to get through to anybody is just be a good example. I sit behind the patient at first, but that's because what I want is for my EMT to actually sit next to the patient before we roll and do everything that they want to do. And I've done my full assessment by the time we've got loaded. So at that point, I want my EMT to perform some assessments, ask some questions. I want to hook the patient up, get the IV. I want them to act like the second medic there. And so I get behind the patient and I do all that stuff. But once the wheels get rolling, I will try to slide back over there and allow the patient to see me and have some interaction with the patient at that point. And, this is the best way is just to model that for the patient. But, you You might just need a conversation. It's always difficult to answer how do you get through to somebody, because not a lot of people are malleable. But then a lot of people who say that they're trying to get through to people also are afraid of having an awkward conversation. And so sometimes you just need to have that conversation. I notice that you sit behind the patient a lot and you don't interact with them. A lot of these patients are lonely and they are afraid, or they're upset or they're stressed, and they feel very alone when they can't see you. And seeing your reflection in the rear window is not the same thing. And it's okay for you to open the Tough Book or whatever, your tablet or whatever, and to get to work, but at least do it sitting next to the patient. They can see that you're doing something, and so it's intuitive to them that you're occupied, but it also feels like you're available at that point. I'm the same way. If I have to question myself if they need it, then they probably need it. Exactly. You never talk yourself out of a good idea. Never back yourself down from a good idea. Need to hydrate myself here a little bit. Just had an 83-year-old female found by staff with blood everywhere. Staff called 2 1/3 hours after they found it. What is this, at a nursing home? Patient does not let us take vitals. Sedate or not to sedate? Do you not know the answer to that question? I am not sedating a patient when I have absolutely no idea what their hemodynamic stability is. And if your patient is capable of informed consent or informed refusal, then they're capable of understanding that they're not going to get something that they need. Why are you sedating them, though? Do they need cardioversion or something like that? Patient is combative. Oh, well, a combative patient is different. A patient that's combative, it probably is not hypotensive, right? You know what I mean? So you're pretty safe there. You can't transport that patient safely. I couldn't imagine that a majority of combative patients are getting their vitals taken. We get patients all the time that are on meth, and trying to get their vital signs. It's like trying to stuff an octopus into a Walmart bag. It just can't be done. And so you just have to do what you have to do. It's Lagavulin, no such thing as too much, right? That is so good. I love that saying, stuff an octopus into a Walmart bag. There's no way to take a blood pressure on someone that doesn't want to have their blood pressure taken. So, you just have to do what you have to do there for your safety and theirs. Damn, a whole bunch of people just sent me messages through Instagram. I love that, by the way. And it happens a lot of times after a live. There'll be 3 or 4 messages in my Instagram inbox from people that just want to ask me questions. That's so humbling. It's so humbling for strangers, to just trust you enough to ask you stuff like that. I don't take that for granted. A lot of aquariums are stopping housing octopi because they're shitty as fuck. Okay. And they're escape artists too. That's the problem with them is, what they can fit through is absolutely amazing. Nothing wrong with not being able to get full vitals sometimes. Just got to document it accordingly. Yeah. And those are times too where if there's any question as to what the patient's activity is, excuse me, I will sometimes take a short video of the patient's activity, but so here's the thing. It's fine sometimes if you just really need some sort of visual evidence of what was happening with your patient. But here's what you need to do if you're ever going to take a picture or video in a situation where you just need to provide some evidence to who you're turning patient care over. Always, 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 always turn on airplane mode of your phone first. That way, once you have shown someone what they need to see, you can delete it before it goes to the cloud. I'd love to hear your thoughts on amiodarone and pre-hospital cardiac arrest. There is no body of evidence that demonstrates any sort of benefit to survival from antiarrhythmics such as lidocaine or amiodarone. No body of evidence. There are some studies that show a little bit of benefit, a lot of studies that show no benefit at all, and most studies have them within the margin for error. There is some data that maybe early on in the code, like the first time that you don't respond to defibrillation, that maybe amiodarone may be beneficial and maybe a little bit more beneficial than lidocaine. But the body of evidence says there's no body of evidence for it overall. Not for any medication in out-of-hospital cardiac arrest of suspected cardiac origin. Never thought of that video idea, and I'm pretty sure we have the capability in our report. Yeah, and if you have a truck phone, you can also use that too. We have a smartphone on our truck, and so we could use that as well. But, if you have to take a picture of a scene, where people are going to be identified, put your phone in airplane mode. What are those emojis? Is that a purse? Something squad, here we come, sleepy paramedic. I don't know what, that is so small that I can't make it out. Somebody tell me what those are. And I don't want to start another war of the sleepy paramedic. I mean, my notifications were a disaster for like a week. I'm not complaining though, because I think that just in that whole croissant war, he probably got me 2,000 followers. Oh, octopi in bags. Oh, I love that. Yes, you are instructed to immediately launch a full frontal attack on the sleepy paramedic with octopi and bags. Tell all your friends. Same here. iPads and Androids. Used to have iPhones that we switched to Logis and only works with Droid. I'm mainly in hospital and like reading my patients' EMS PCRs if I have time. I had a Metro PCR. That's pretty cool. Shit, what have I done? You have started a war. Do it. Tell everybody. I'm seriously, if you have followers, get on there and do it. If there's something you can share, let's send octopi and bags. It doesn't even have to be a bag. Well, no, I guess they have to be together. But we have to send octopi, and bags to the sleepy paramedic. I love that whole thing. It's so funny. Hold on just a second. Hey Google, set the downstairs temperature to 68 degrees.
Sure. Setting downstairs thermostat to 68 degrees.
We have a group chat, myself and Greg from Shade Tree Cardiology, Jenna, Roxbury, and Sleepy. We have a group chat, and we were having a lot of fun talking about the croissants and stuff like that. And by the way, we will be having a Discord channel that all of us will be a part of soon. Hi, I just started AEMT school with no experience. Any tips of how to study this vast amount of info? Well, you're not studying it all at once. So the question is, how do I eat an elephant? And the answer is one bite at a time. But you can benefit yourself by getting ahead on your reading, that's for sure. Whatever chapter you're going to get into, read that chapter twice before class and read it once immediately after class. And that's all you really need to do. You'll sail through school. Any benefit from medic's perspective, if basic partner has ACLS PALS knowledge. I mean, if you're both speaking the same language, that's only a good thing. There's a lot of EMTs here that have gone through ACLS, and I find it very, very helpful to have them know what I'm talking about. I don't know if my message went out. I just sent you a message about that. Did you send it through Instagram? If you did, I certainly got it. I can't check it right now. And once I get off live, I'm going to go straight to bed, so I'll check it in the morning. Oh, on TikTok? Let me see if I follow you, because if I don't follow you, then you can't send me a message. Okay, I'm following you now, so you can send me that message. %. When your EMT knows what you're doing and why it helps with the workflow. Yeah. When you're both speaking the same language, that's fantastic. And, you know, any knowledge that an EMT can get is only beneficial. I'm starting to get tired now. And I just heard the secret signal from my girlfriend, which is the opening and closing of the bedroom door, meaning why aren't you in bed? So, going to be getting off here soon. We're back to reading and highlighting for me. The best thing you can do, the best way to study is not to cram. You know, one of the best ways you can study is just take different color highlighters and break up the text that you're reading into different separated thoughts. That's such an easy way to study. Okay, so I'm old as dirt, apparently. All these kids and this AEMT stuff. Yeah, I mean, when I came up through EMS, it was basic, intermediate, and medic. Have a good night, everyone. Thanks for the live. Thank you for being here. So, let's see. That's the end of that. Questions have slowed down. I'm getting tired. So I think I'm going to end it right here. This has been like a 2-hour live, so this has been fantastic. I appreciate all the interactions from everybody. I appreciate the follows, the likes. You guys are awesome. And just hope you guys have a good night and that you stay safe. Thanks a lot, folks. We'll see you later.